First off, I know that the invitation said we would be discussing both balance and Palisade studies, but the plans changed just a little bit. We're only going to be discussing balance today, and we'll discuss the other study at the next journal club from the Southwest Lipid Association. The reason for that is that we want to have an in-depth discussion, and it's probably easier to do that if we just do one study at a time. So just to give you guys a little bit of background, SWLA is a Southwest Lipid Association. And for years, we have not been doing any kind of programming, unlike the other regional National Lipid Association sections. But we did meet this past July, and we wanted to develop some programming. And some of the things that came out of that meeting were that it had to be something that wasn't too much work and was not at night. Many of us do have kids and families, and although it seems like it would be easier at night, the members of the Southwest Lipid Association did not agree with that. They wanted to do something during the day, during working hours, so that they wouldn't have to worry about their kids or other things. What we came up with was to do a journal club, a kind of an old school approach to do a very critical review of a published study that's relevant to the lipid field. And today we're going to be talking about balance, which is a study of olezarsen. And I do apologize if there's any of the sponsors on the call. This is a critical review, so we're going to say good things, and we may say things that aren't as good. But overall, of course, we want to be balanced. These are some of my disclosures. I'm on some adjudication committees. I am a site PI for studies from Ionis and get some investigator-initiated research funds from Ionis. And I actually am or was a site PI for balance, but I didn't have a patient that passed screening. And I actually totally forgot about this until I was looking at the supplementary material for this, for the paper, and saw my name there. And I'm like, oh yeah, that's right. We tried to get some patients in and didn't work out. So this is a study we're going to be talking about, published in New England Journal on May 16th, 2024, olezarsen acute pancreatitis and familial chylomicronemia syndrome. Now let me stop here and just put down a few ground rules. First of all, please interrupt me at any time. You're more than welcome to say anything you want. We have a chat that you can type in at any time you want. This wasn't intended to be just me giving a lecture. The original intention was that this would be an interactive type of lecture, not lecture, I guess, interactive forum. Now, this is the first time we're doing it, so we don't really know how this will turn out, but we do really want to hear everyone's opinion and questions. I do have the manuscript as a PDF, as well as a few of the supplements opened up right now if we need to take a look at that. We may even have some of the investigators on the call, so I'd love to hear your input. I do see some names that have done work in lipoprotein lipase physiology before, and so I'd love to hear your input too into this. So please feel free to chime in. I will try to maybe pause every now and then. Is there someone who wanted to say something? Okay, never mind. So quick background, just enough that we understand this study. This is what I usually tell people is the first case of familial chylomicronemia syndrome. There may be cases before this that described eruptive xanthomas or other things, but this is what I could find, and this is from 1932. So this young boy was the male offspring of a consanguineous marriage, and he had these eruptive xanthomas on his skin. He had hepatosplenomegaly, which is why his abdomen is protuberant, and his plasma was noted to be milky. Now, these scars on his abdomen are actually from multiple surgeries looking for the underlying cause of his abdominal pain, because he would have very frequent abdominal pain, very severe abdominal pain. Of course, no particular cause was identified through the surgery, but it was noted that in the perioperative period when he was NPO, his plasma was less milky. Not that it was completely clear, sorry, it may be incorrect here, but it was less milky. And then he was eventually treated with a low-fat diet. So I like to show this because the treatment for this young man was a low-fat diet. And the treatment today for FCS is still a low-fat diet. We have yet to develop a pharmaceutical agent that would be very efficacious for these individuals. And let me just spend a minute talking about what familial chylomicronemia syndrome is, or FCS. This is an autosomal recessive disorder and is characterized by a reduction or almost absence of lipoprotein lipase activity. And that results in a pathologic persistence of chylomicrons. And so when you measure triglycerides, they persistently measure above 880 or 1,000. The only time they might measure lower than that is maybe when the patient's hospitalized or gets plasmapheresis or something like that. This definition is something you will see in the FNLA statement for FCS coming out probably early to mid next year. We will have an expert opinion statement on FCS itself. The prevalence is thought to be 1 in a million, although there are more modern papers, modern genetics papers, that in some areas it might be more prevalent, like 1 in 100,000. Unfortunately, the vast majority of these people, as a result of having such high triglycerides, they experience pancreatitis, 60 to 90%, depending upon the case series. Right now, the main way we diagnose is genetic screening. The ideal way would be to measure LPL activity or mass, but this is not commercially available. There are several genes that need to be screened. So if you do want to do genetic testing, please do make sure that these genes are on the panel that you're looking at: LPL, GPI, HBP1, ApoC2, ApoA5, and LMF1. There are some commercial labs like GB Insight or Invitae that have lipidemia or dyslipidemia panels that include these genes. There are also some people who will not have mutations in these, but clearly have FCS. They have all the characteristics. For those people, they're kind of being labeled as what's called functional FCS. And there are some clinical scoring systems that can be used. There's 3 now, I think, 2 from Europe maybe, and 1 from North America that should have just been published in Journal of Clinical Lipidology. The differential diagnosis, so this is important, and this was actually a large part of the FNLA's expert opinion paper on FCS, is how do you distinguish it from MCS? Because MCS typically does respond to treatment, whereas FCS doesn't. By treatment, I mean the currently available lipid-lowering drugs that lower triglycerides, fibrates, and omega-3s. Or MCS patients have multiple things that cause triglycerides to get high. Dr. Ginsburg points out in the chat that some patients can maintain triglyceride levels around 500 by eating almost zero dietary fat. Because I have actually seen that too. That's a great point. That this is, again, the main treatment is reducing dietary fat. Dr. Ginsburg, did you want to say something?
Yeah, I was just going to say, and I meant these are patients, not the multifactorial. Many of them go below 500 when they take care of themselves. But even true genetic homozygous loss of function, FCS patients, I've had 2. Ivor Goldberg's had a couple, and they have BMIs of 18. They eat essentially no fat in their diet, and they keep their triglycerides 500 or below on no treatment. Now, if they're females and they get pregnant, then they blow up the 3rd trimester, certainly.
Yeah, I'm glad you brought up the pregnancy thing too. That as maybe in a discussion later on, that is a question I have as well, as what are we going to do about pregnant women who get this, or women who want to get pregnant, who may get this drug. But yeah, thank you for sharing that. Do you ever use MCT oil as a source of dietary fat for these individuals?
I use it as often as I can. It's very expensive. It's very hard to get insurance coverage, but it's a way to make life a little bit easier because they can use it as a dressing. They can use it to cook with. But now with air fryers and fake fat sprays, a lot of them, the couple of patients that I have do that. But MCT can be a really good way to get calories, especially in the children. And it's absolutely safe.
Yeah, thank you for sharing that. I've not had as much luck. We do follow quite a few genetically proven FCS patients here in Dallas, and the few times I've tried to get them MCT oil, they just get horrible diarrhea, and maybe they're trying to use too much too quickly. The kids seem to do better. My pediatric colleagues have a better experience with it. Okay, the other thing on a differential diagnosis that always gets forgotten is lipodystrophy. So you may note, or if you ever see pictures of people with lipodystrophy, they have very little subcutaneous fat. In fact, sometimes they even look like bodybuilders. Their arms and muscles kind of pop out, and they may even have a six-pack of abs, but they store fat in the liver or in other places in the body that causes a lot of metabolic issues. And they may be thin individuals similar to FCS who have very, very high triglycerides and don't have any major secondary issues causing that, like MCS would. But we will discuss much of this in our expert guidelines coming soon. The treatment, as we've alluded to several times, is a very low-fat diet. There is a very small study of 2 kids with FCS. It's a multiple crossover study showing that orlistat can lower triglycerides in these individuals. That is just it's just building on low-fat diet, because orlistat, which is over-the-counter as Ally or prescription as Xenical, orlistat is an intestinal lipase inhibitor, so it does block fat absorption. And then one of the key things about these individuals is that they're refractory to pharmacologic treatment. So there are drugs in development. This is a very simplified schematic. The 2 sources of cholesterol and triglycerides, the 2 major sources are the liver, in which you absorb in the small intestine, and they get packaged into triglyceride-rich lipoproteins that are acted upon by lipoprotein lipase, the enzyme, and you get remnant particles after they're acted upon. So with chylomicrons, you get chylomicron remnants. With VLDL, you get IDL and then LDL. But the problem with FCS is usually, or is always, some issue with lipoprotein lipase, that either lipoprotein lipase has mutations or its cofactors have some issues, or anchoring proteins like GPI, HPP1. And so people have tried lots of different things in these patients. One target was ANGPTL3, which is an inhibitor of lipoprotein lipase. So several drugs either are in development, or evinacumab is actually available for homozygous FH. They inhibit ANGPTL3, and so they're inhibiting the inhibitor, which should activate lipoprotein lipase. But evinacumab, when it was studied in people with high triglycerides of varying different genetic backgrounds, those who had FCS mutations did not respond to it. That does make some sense. Lipoprotein lipase, if it has, if it's not functional, trying to activate it probably wouldn't do anything. In contrast, inactivating ApoC3, which is also something that inactivates lipoprotein lipase, you're again inhibiting an inhibitor, but somehow that does lower triglycerides. And the first drug to show that, and I'll show that data in a second, was volanesorsen. That had a side effect, and so the second generation of that is an antisense oligonucleotide called olezarsen. And there's also an siRNA called plozasiran, which was going to be the other topic we're going to talk about today, but I don't think we'll have time. So we'll save that study, the Palisade study, for the next time. So probably, I don't think anyone really knows why targeting ApoC3 lowers triglycerides in these individuals. If anybody on the call has more insight than I do, please share. What I hear most of the time is that other lipases that can also catalyze the hydrolysis of triglycerides, if those lipases, like endothelial lipase or hepatic lipase, if those get activated, and that may be why.
Yes. Zahid, if I may interject, there's a literature from the 1980s is very clear in rodents that ApoC3 inhibited the uptake of remnant-like particles by the liver. And they have, the LDL receptor probably involved in more recent mouse studies from Ionis and Joe Whitstone and ESCO, that there's a VLDL receptor in the liver, there's an LRP, there's an LDL. And so the hypothesis has been, and has not been proven, that if you, with C3, inhibitors, you'll open up that pathway and will in part compensate for the lack of any LPL activity. But it's not been shown in any particular study. Maybe a little bit of evidence from some of the mouse knockout kinds of studies that have been done.
So, but that would be the remnant particle, right?
Well, so that is a good point, and so maybe there's a little hepatic lipase that comes in there, and you make some remnants. You have to. There's one basic point. People with FCS, in general, they may be running triglycerides of 2,000 or 3,000, but they are making some VLDL. They're eating a little bit of fat, so they're at steady state. So the particles are going somewhere all the time. Right? It's not an ever-ending rise. Where they go is not well known, not clear.
Yeah, that's really interesting. You may have to do the studies yourself to teach us. I don't know. So a little bit about ApoC3. I'm certainly not the world's expert on ApoC3. I'm learning about it, same as everyone else. But it does come in various glycolytic forms, which I don't know if it's relevant to FCS patients or drugs that target it, but it's typically produced in hepatocytes or in enterocytes in the intestine, and incorporated as lipoprotein in lipoprotein, VLDL or chylomicrons. And as I mentioned, it inhibits lipoprotein lipase. There's also some free ApoC3 too that I guess may be involved in atherosclerosis or other things. But whenever we're increasing VLDL production in the liver, we're also increasing ApoC3 production. So things like obesity, alcohol use, estrogen, they do kind of not just increase VLDL, but also increase the inhibition of lipoprotein lipase via ApoC3. That may not be relevant to this particular study, but as I said, I'm still learning about ApoC3. I mentioned that the first evidence that ApoC3 would be a viable target for FCS was volanesorsen, and this was the study by Daniel Gaudet in Canada, and they gave volanesorsen, which is an antisense oligonucleotide, to ApoC3, and showed that it reduced ApoC3 levels as well as triglyceride levels. And you'll note that these patients got down to 500 sometimes, which is pretty impressive. That's not something we can do right now with currently available drugs. But, and many of you probably know the story, as the drug was studied more and more, there were people who got thrombocytopenia. And that wasn't thought to be due to the target, ApoC3, but rather the drug delivery and the very high doses necessary. And so the second generation of this drug was olezarsen, which is the same drug as volanesorsen. It just has GalNAc attached to it, and therefore it can be given in lower doses since it's targeted to the liver easier. And so the BALANCE study was a phase 3 multi-center double-blind randomized placebo-controlled trial of olezarsen, which again is a GalNAc-3 conjugated antisense oligonucleotide that targets ApoC3 and reduces its production at the mRNA level. The study was done in 29 centers in 11 countries and took place from 2020 to 2023. Okay, there's a good question here that maybe Dr. Ginsburg or someone else could answer. Could you please explain how lipid level is increased during pregnancy?
There are very, very old data, I think using chickens originally, that showed that the liver would make a VLDL-like particle that would bring energy to the placenta. And in general, there have been studies, obviously not the kinds of kinetic studies where you'd use, take a lot of blood and use traces in humans who are pregnant. But if you look at women, there have been studies of women taking estrogen in various doses with or without progesterone. And estrogens increase the secretion of the synthesis and secretion of triglyceride and VLDL from the liver. And most likely, if a woman has very good clearance mechanisms, their triglycerides will go up a little bit on oral contraception, or in the third trimester of pregnancy when estrogen is very high, and not a problem. But if a woman has some predisposition like multifactorial chylomicronemia predisposition, then we all see cases of women going on estrogen and getting pancreatitis, or third trimester women who nobody thought ever had a triglyceride problem getting pancreatitis with triglycerides in the thousands.
Yeah, thank you, Dr. Ginsburg. Yeah, my experience, actually my very recent experience, so I got a message from a colleague saying that one of our colleagues at our institution ended up in the emergency room in the third trimester of pregnancy with lipemic plasma, triglycerides in the thousands, and pancreatitis. And she's fairly young, in her 20s, and had never really even had her lipids measured before, for whatever reason. And so I've been following her since then. She's almost ready to deliver. We've been doing weekly checks of her her triglycerides, and they're at least staying below 1,000. And the plan is, I guess, to do plasmapheresis if they get much higher. I don't know exactly what the cutoff should be, but to prevent pancreatitis, we may have to do it. And when we did genetic testing, she's actually a heterozygote for ApoA5 mutation. So I suppose that what's happened here is that she has a genetic background where she's heterozygous. She's not FCS, she's more like an MCS, but that plus the high estrogen and increased VLDL in the third trimester of pregnancy probably raised her triglyceride levels or saturated her lipoprotein lipase or something.
Yeah, I'm giving grand rounds at Columbia to the OBGYNs because that as a field, those people don't think about triglycerides, and they have and they don't screen women for triglyceride levels when they put them on any side of estrogen. And now a lot of women are trying to harvest eggs and freeze them away, and they get clomiphene, which has some complicated actions, but one of them is a pro-estrogenic or is an estrogen receptor ligand. And there are women who've developed pancreatitis while they've been trying to get when they've been getting hyperovulation for either freezing eggs or for IVF preparation. Wow. They're not screened in advance.
Yeah. And in the chat, Arigato also points out that insulin resistance is also a factor in pregnancy.
Right. And women with PCOS they usually have triglycerides of 150, 200, 250. And estrogens can, in some of them, blow them up into the thousands. Not all of them, but some of them.
Okay, follow-up question. Does estrogen increase cholesterol too, or triglycerides only? Well, when you increase triglycerides, you're increasing mostly VLDL with estrogen, and that will have cholesterol as well. So you do increase cholesterol in those particles, or measured cholesterol, yes. Okay, let me keep going. So in terms of balance, so back to our study, they had a goal of enrolling 45 patients, and they did exceed that goal. This is the major inclusion-exclusion criteria that I think is always important, because I always think about, would my patient have qualified for this study? But this is for adults, so age over 18. They had to have FCS confirmed by genetic testing. The triglycerides had to be measured above 880 during the screening period. I apologize, I wrote that twice there. They had to have a history of pancreatitis, although a few patients were allowed in with no history of pancreatitis. That was pre-specified in the inclusion criteria. They had to be able to follow a low-fat diet and agree to follow it throughout the study. They had to be on a stable dose of lipid-lowering medications for at least 4 weeks. And then we're talking a lot about pregnancy, but actually in this study, women had to be non-pregnant, non-lactating, and not at risk for having a child, essentially. So they had to be either surgically sterile, postmenopausal, abstinent, or agree to highly effective contraceptive methods. And even men had to be surgically sterile, abstinent, or using highly effective contraceptive methods. And then the exclusion criteria included pancreatitis within 4 weeks of screening, which is actually how one of my patients got excluded. They were doing okay, but then got pancreatitis during the screening phase. The platelets could not be below the lower limit of normal, or they could not have a history of platelets below 75,000 millimeters cubed. They couldn't have an ALT above 2 times the upper limit normal, a GFR less than 60, couldn't have HIV, hepatitis C, B, or malignancy, couldn't be on niacin, steroids, GLP-1s, or plasmapheresis. And there's more inclusion-exclusion criteria. These, I thought, were the main things that are probably relevant clinically to us. And this was, as I mentioned, it's a randomized study. It was actually 2 different doses of olezarsen. And the way the randomization worked was that first patients were randomized to either be in the 50 milligram group or the 80 milligram group. That was a 1-to-1 randomization. Then it was a 2-to-1 randomization that they would either get olezarsen at the 50 milligram or a 50 milligram matching placebo. And same with 80 milligrams, 2-to-1 would get olezarsen at 80 milligrams or an 80 milligram matching placebo. And when you see in the results what they call placebo group, it's actually the total of these 2 groups. So either they were getting the 50 milligram placebo or the 80 milligram placebo. And then in terms of primary endpoints, this was statistically done in a hierarchical fashion. I'm not a statistician, so please, if anybody understands this better than I do, you're welcome to chime in. What I understand this to mean is that they had to meet the first endpoint, then the second endpoint could be statistically relied upon. And the same thing with secondary endpoints. Only if the primary endpoints were met, then the secondary endpoints could be relied upon. So the first primary endpoint was a difference in percent change in fasting triglycerides from baseline to 6 months. So note in the lower right, there's a diagram of the overall study design, the randomized period at least. There's an open label period after this. But the primary endpoint is at 6 months. The study actually went on for almost a year. So they kept getting the drug, but at 6 months was the primary endpoint. And it wasn't a one-time triglyceride measurement. I think it was over a few weeks that it was measured and then pooled. The data was pooled. But the primary endpoint was the 80 milligram group compared to placebo. And if that was met, then the second primary endpoint could be analyzed statistically, which is a 50 milligram group compared to placebo. And if then both of those are met, then the secondary endpoints are analyzed in a hierarchical fashion. There were 28 different secondary endpoints. Many of them had to do with ApoC3 levels or the triglycerides or ApoC3 levels at the last dose, after the last dose, in roughly a year. Secondary endpoints numbers 13 through 16 all had to do with pancreatitis events. And that's important. I'll kind of go into a little more detail why I think it's important later, but this is the consort diagram that kind of helps us understand how the patients flow through the study. So 144 patients were screened. A lot got excluded, 78 got excluded. And that might be what you expect with the FCS that has to be genetically proven. Genetics does weed out a lot of people who we think have FCS, but either they have something else or they have FCS and we just can't find the mutations. 66 were randomized, 23 to placebo, and amongst the 23 to placebo, 22 completed the study. 21 were randomized to 50 milligrams of olezarsen, and out of that, 19 completed the study, and 22 randomized to 80 milligrams of olezarsen, and out of that, 19 completed the study. So overall, it seems like they actually had pretty good, pretty low dropout after people were randomized. This is the demographic and clinical characteristics. I'm sure no one can actually see this, so let me share my screen that has the actual PDF that I can zoom in on. Hopefully you can all see this. Can someone tell me that they see it?
Yep.
Okay, good, thank you. So the age was in the 40s. Overall, I think that it was overall pretty well balanced between the three groups, but just to give an idea of who the patients were. There was, I think, a little bit more females than males, but not really that dramatic. It was mostly whites. So the ethnic racial diversity was not huge. The weight was, most of the people were in the were around 60 kilograms or so, BMI 20s. A large proportion had a history of pancreatitis in the previous 10 years. There were people with diabetes. And I presume that this is either type 1 diabetes, which would happen just by chance as an autoimmune condition, or it says type 2 diabetes, but again, that could happen by chance. People with FCS can have type 2 diabetes. Or it could be people who had recurrent pancreatitis and developed pancreatic diabetes, which sometimes we call type 3. But there's different terminology for that. But I think there was a pretty reasonable number of diabetics. I was kind of surprised to see this part. Everything else I think was pretty balanced. The triglyceride levels, the means were 2600s roughly in each groups. The medians were, about the same, 2000s, 2600s, about 2500 in the three groups. Is there anything else anyone sees in this table that might make you think that the groups were imbalanced, or that there was some source of bias here? Okay. I usually just look at these tables to look for those things. Is there imbalance, or is there some bias that you can pick up from that? So I will move on then, because it's already 12:35 at where I am. I'm also very much into genetics. Okay, so Arigatu mentioned that he would have liked to see hemoglobin A1C. Yeah, that might be in a supplement somewhere. I'll go back and take a look. If anybody has a chance and can take a look, please do. But in terms of genotyping, most of the patients had LPL mutations, which is what you expect. That is the most common cause. The second most common cause was mutations in GPI-HBP1, which again is consistent with clinical experience. That is usually the second most common cause. And the third most common cause was mutations in ApoC2. Carol, thank you for taking a look to see if you can find the A1Cs. I will note, the one thing I noticed looking at this or making this table was that the 80 milligram group did have slightly more complex genetic background. They had a hemizygote, which is someone who is missing the entire gene. Usually they're missing the entire region. One copy, not both copies, but one copy of the entire gene or that entire region. And then there was someone who's double heterozygous, meaning they had a mutation on one allele of LPL and one allele ApoA5. I'm presuming this would be the same person. So they have two different genes knocked out. Oh, sorry, heterozygous mutations, two different genes that combined give you the same phenotype as FCS.
So Robert Hegley now says that geneticists are starting to call that digenic.
Digenic?
In order to separate them from, you have compound hets, which are two different, let's say, two different mutations in LPL, but it's all two different mutations in GPI, but they're the same it's the same gene. But that one double het is probably somebody had heterozygous LPL and heterozygous whatever, GPI or C2. And now the terminology that Rob Hegley says is being used is called digenic, since it's completely different genes. You have to be pretty unlucky to get two genes that are 1 in a million mutations.
Yeah, that's very true. That's very true. That's good. That terminology is better, I think, because that makes more sense. Double het always seems to confuse everyone. Yeah. Okay, very good. And then we'll get to the results. So this is the fasting mean triglycerides at 6 months. So this is a primary endpoint calculated from an average of the triglyceride levels at week 23, 25, and 27. So again, that's not the that's not the right side of this graph, it's the middle. And at baseline, the mean triglycerides were 2630. I will actually show the absolute values in the next graph. It was in a supplement that I could find. In the 80 milligram group, there was a 43% reduction, mean reduction in triglycerides. So that's the blue line. And that's statistically significant. The 50 milligram group was a 22% reduction, and that's not statistically significant. So the 50 milligram group compared to placebo did not achieve statistical significance. Again, this is mean reduction. I am curious if anyone thinks that it would have been better to do median reduction. Generally speaking, whenever I don't have a ton of experience publishing in the triglyceride field, but when I have, you usually represent triglycerides in medians because they do kind of have a right shift or left shift. It's not a perfect Gaussian distribution in the population. Okay, no opinion. That's fine. Maybe I'm the only one who thinks about it then. This is the absolute reductions, and you'll see that the error bars are quite wide, and that's what you expect. Triglycerides, as I mentioned, do have a lot of deviation. But you can see the olezarsen 80 milligram group dropped people from 2,500 down to the 1,500 range or so. That's the 80 milligram group. The 50 milligram group was still close to 2,000 sometimes, maybe 1,750, something like that. And clinic, we always talk about trying to get the triglycerides below 500 for MCS patients. If we use that as a marker here, 3 out of the 22 patients in the 80 milligram group got to below 500 at 6 months, but none did in the 50 milligram group. And this is the individual patient level data at 6 months. So this is percent change in triglycerides with placebo in black, 50 milligrams in the gold yellow color, and 80 milligrams in the bluish color. And it does seem like the 80 milligram dose worked for more of that group than the 50 milligram dose worked for that group. Some people in 50 milligram group increased triglycerides quite a bit. Okay, so circling back to the A1C question, Carol did look and said she couldn't find A1C data in the main publication or supplemental materials. That is my recollection too. I don't remember seeing that. But she did find the sentence in the main publication saying that in an exploratory safety endpoint analysis, no major changes in the glycated hemoglobin level from baseline to week 53 were noted in any of the 3 trial groups. So there was no change in A1C in the study. I guess that doesn't really tell us about the baseline diabetes control. And I don't recall seeing diabetes control as being an exclusion criteria in this study. So that could be a confounder if there were uncontrolled diabetics somewhere in the study. Okay, now pancreatitis events. So when volanesorsen went to the FDA, I actually did read the FDA briefing documents. They're very long, but they're very educational. And they did point out that at the time, they considered triglycerides as a surrogate marker for reduction in pancreatitis risk. And that's because the pancreatitis had not really been included as an endpoint in many studies of triglyceride-lowering drugs. But starting with volanesorsen meta-analyses, and now olezarsen, and also the other siRNA for ApoC3, pancreatitis is an endpoint, not a primary endpoint, but an endpoint, usually secondary. And I do want to point out that this is exploratory because the study did not meet the second primary endpoint, which is the 50 milligram versus placebo. So this is exploratory, but it does seem pretty compelling. There were, I think, 9 patients and a total of 11 episodes, 9 patients who had pancreatitis for a total of 11 episodes. 13 episodes. 11 of those were in placebo, 1 in the 50 milligram dose and 1 in the 80 milligram dose. And all of these individuals actually had had more than 2 pancreatitis attacks prior to enrolling. So this to me is reassuring that that this drug, even the 50 milligram dose, did seem to reduce the amount of pancreatitis episodes by lowering triglycerides, and that triglycerides is a reasonable surrogate marker for pancreatitis risk. If there's anyone who looks at this differently, please feel free to chime in. There are also some pre-specified exploratory endpoints, specifically LDL and ApoB, and this is data that's in the main publication, written in text, not in table format, but I turned it into a table because it's easier to understand. LDL cholesterol did go up in the 50 milligram group and in the 80 milligram group. In the 50 milligram group, it went from 18 to 23, and in the 80 from 23 to 38. ApoB levels also went up. They did go up in placebo as well, a little bit, 60 to 65. In the 50 milligram group, they just increased slightly, 65 to 67. In the 80 milligram group, it went from 58 to 69. Dr. Ginsburg or anyone else who is one of the pioneers of understanding lipoprotein metabolism, I assume that this is what you would expect. If you lower triglycerides, you probably increase the amount of remnant particles and IDL and LDL, and so LDL and ApoB would go up.
It's really hard with these people. For instance, real genetic FCS, VLDL secretion is often normal, unless they are so unlucky to get insulin resistance, metabolic syndrome, diabetes as a second disorder, or even as a secondary disorder. So you wouldn't, the LDLs, why do they go up at all? In typical hypertriglyceridemics, LDL cholesterol goes up for several reasons. When TGs go down, there's better conversion, as you said. There's particles actually cleared more slowly, and it's richer because of cholesterol as a transfer protein. There's more LDL in every particle. So this might be a little bit of CTP. You're knocking down TG so much even in the chylomicron fraction that there's less movement of LDL cholesterol into the chylomicrons, which happens to all of us postprandially. The ApoB is a little more complicated because there's B48, which is dramatically increased in these patients, and B100 is, not high and maybe even on the low side. So it's something that hasn't. These are so rare, these patients. It's hard to really get the details you can get in a normal or even mildly hypertriglyceridemic population.
Thank you, Dr. Ginsburg. That helps. Helps me at least think I was thinking about it in somewhat of the right way. Carol also points out that it'd be interesting to see the differences between study design and results between Balance and Palisade in the next journal club. Yes, that was actually the original intent, but there's no way we would be able to do that in 1 hour. So, but just as a quick spoiler, Palisade included people who didn't just have genetically proven FCS. It did also have people who have persistent chylomicronemia. They have MCS, but their triglycerides just stay high. And then they also analyzed the data differently. They looked at median triglyceride levels, not mean, or least mean squared mean. But let me move on because Kathy just sent me a message saying we have a hard stop in 13 minutes. This is the adverse events, and I did look at this as much as I could. I also looked at the supplement as much as I could, and to me, I didn't notice anything that really stood out. In the supplement, they have a row that says platelet count decrease. There is another thing that says, in the main publication, I think there's a row that says reduction in platelets, and that one is 0 for all groups. But platelet count decrease in the supplement did have people, especially in the 80 milligram group, that had more decrease than in placebo or 50 milligram group. again, it's small numbers, it's hard to understand. And then this is an injectable drug, so injection site reaction, is going to happen. To me, that's not really a huge issue. But in the text of the study, you'll notice it does say that there's no differences, no imbalances with liver function, renal function, or A1C. So, in summary, olezarsen 80 milligrams every 4 weeks reduces triglycerides significantly more than placebo in patients with genetically proven FCS. The safety profile seems favorable, and in exploratory analysis, the pancreatitis risk or pancreatitis incidence is reduced. And there are limitations, and there are a lot of questions in my mind. One limitation, obviously, sample size. This may not be a big enough study to pick up any safety signals, but there are studies ongoing with larger populations that may pick those up. There's also lack of racial diversity or ethnic diversity, and at least in Dallas, a lot of our patients with FCS or MCS are Hispanic origin or South Asian origin. And so whether or not these drugs may have a different effect, there's no reason to think they would, but you never know, they could. We talked about including diabetes, and we don't know the A1Cs. Another question is 43% triglyceride reduction enough? That's not as much reduction as volanesorsen seemed to show, but the pancreatitis risk went down, so it's kind of hard to argue with some reduction, I guess. There's a question of how the data was presented, median instead of means. There's another question, like if you look at the 12-month data, if that was the endpoint, it probably would have looked better. At 12 months, the 80 milligram dose reduced triglycerides by 59%, and the 50 milligrams reduced by 44%. And in exploratory analysis, those were statistically significant. Another question, I think we're all spoiled by PCSK9 and how safe of a target that is. And we can knock out PCSK9 almost completely and have no safety issues. But that's not necessarily true of everything else. So we're knocking out ApoC3 by 70 to 80% with this drug. Are we going to find some off-target effects at some point in the future? The follow-up or the long-term studies will kind of help us understand that. What about increasing LDL and ApoB? They're not huge increases, but would that change ASCVD risk? And generally speaking, people with FCS are not considered to have high ASCVD risk if they don't have traditional ASCVD risk factors. There's always a question about patient perspectives. What do they think about it? Did their life get any better? One way their life could have gotten better is from diet. But could they have loosened up their diet? In this study, they were told to not do that. I believe there is diet data in the study, so I'm sure there are people who did loosen up their diet, and we can kind of see at some point if the triglycerides went up. We also discussed a lot about pregnancy or about lactation. FCS is a condition that starts in childhood, and so what do you do if someone's on the drug and wants to have children? What will this drug cost at some point? Will it be an orphan drug or will it be a non-orphan drug? And then, a more fundamental question that hasn't been shown in humans, or the answer has not been identified in humans. How does reducing ApoC3 really lead to reducing triglycerides in an FCS patient? So I will stop. Go ahead.
Can I just interject on that last point?
Yeah.
The Amish population in Lancaster have significant, a small number of people who are heterozygous for ApoC3 loss of function. They have no homozygous patients. In Pakistan, where there's a huge genome program ongoing, they have a significant number of identified heterozygotes. They also had at least one family with both parents as heterozygotes, and both parents actually were homozygote, and also all the children were homozygote. But for the heterozygotes, they seem to do fine in terms of general health, and they have lower triglycerides. And we did some stable isotope studies, and in Scandinavia, another group did stable isotope studies looking at ApoB and TG metabolism in people with heterozygous loss of function of ApoC3. And there's no doubt that lipolysis is sort of 2 to 3 times faster. So the reason triglycerides are down if your C3 levels are lower than the general population, it's because your LPL works better. In terms of whether the liver is taking up stuff faster, that's harder to show even in those sophisticated studies. It doesn't look like it might be. It might be the LPL, so the increase in LPL activity dominates. And so I think knocking down ApoC3 70% should be fine. There again, the Amish not having any homozygotes in that closed population, raises an issue of something in utero, and maybe that's true in Pakistan, where there's only, I think, maybe 1 or 2 families that are homozygotes.
That's interesting. Huh. I'll have to look into that Pakistan data a little bit more. I didn't know too much about that.
It's hit that the ApoC3 data is hidden in this very big paper by a guy named Danesh Salehin.
Oh, okay.
Where he just describes the Pakistan population. It talks about a number of different genetic mutations where he can find homozygous, because about 20% of marriages there are with first-degree relatives. And he had one family that he showed some data where they were homozygous. I think there's another paper somewhere that's being written now about Pakistani project and homozygous loss of function.
Okay. Very cool. Okay, so there's a few comments and questions in the chat. One is the question about, does the same apply to triglycerides? The lower the better, LDL cholesterol. Any dangers of 0 triglycerides? Okay, so the question is, if we push the triglycerides all the way down to 0, would that be a problem?
It all depends how you do it, right? If you block VLDL secretion, you'll end up with fatty liver under most circumstances. If you increase lipoprotein lipase activity or hepatic uptake of remnants, then you can get very low triglycerides, and there should be no significant metabolic consequences. And I think everybody has patients that have they're not common in America anymore for sure, but there's still people who run triglycerides of 50 or 60. And they're usually thin and eating a good diet and exercising and have good genes.
Yeah, I certainly I've seen the A beta and hypo beta patients. So they have low triglycerides, but as Dr. Ginsburg pointed out, that's because they can't make chylomicrons in VLDL, and they get they get a lot of problems actually, fatty liver plus vitamin deficiencies.
But there's a form of hypo beta due to ANGPTL3 loss of function, which seems to not have any obvious, at least in the few studies that have come out. There's one from an Italian village that was famous for having a founder gene and a lot of relatives with heterozygous ANGPTL3, and they seem to do well with low levels of TG and HDL as well, and LDL.
Okay, so then the last comment, we just have a few minutes left, but the last comment is from Carol Kirkpatrick, who encourages all of us to listen to the Lipid Insight podcast. There was an episode about the other study that we were originally going to talk about. That study is Palisade of the siRNA for ApoC3. And they actually, it's Alan Brown interviewing Rob Hegley and talking about the study. And I have listened to it. It's actually a very good podcast. So if you, sorry we couldn't talk about Palisade today, but if you do want to, the NLA does have some material that you can listen to with regards to discussions about that study too. So I apologize to anyone who read through Palisade and now we're not talking about it. Thank you, Ronald Musa. She says something very nice, that this was outstanding and we need more of these journal clubs. I'm very encouraged. We had almost 50 people join today. That's fantastic. And we will keep doing this.
Thanks, Zahid. It was great. And
Good.
no worries. I'm looking forward to next month when we'll talk about palisade. I think it made total sense to just discuss balance today. It allowed to go into a lot more detail. So thank you.
Hey, you're welcome, and thank you all for joining. We really do appreciate it.